All right, welcome everyone. So I'm pleased to introduce Professor Rod Jackson. He is a professor of epidemiology at the School of Population Health here in Auckland. So Rod is medically trained and also has a PhD in epidemiology. He is a fellow of the New Zealand College of Public Health Medicine, and he has 35 years of experience in cardiovascular.
That's why the grey hair.
Epidemiology. So his research interests are in understanding and influencing trends in cardiovascular disease event rates, both at the population level and at the level of individual patients. And he leads a big health data research program that generates very large cohort studies from web-enabled clinical studies that are linked to the National Health Database. So he is planning to use this to implement, monitor and improve cardiovascular disease risk assessment and management, both in the primary care and secondary care settings. And that's what is going to be.
Great. You've given my talk already. So, so thank you very much. I was here, did I come 5 years ago or something? Was it longer?
No, it was shorter, wasn't it?
Was it shorter? God, time flies, doesn't it? Yeah. So thanks for the invitation. So it was interesting when you said I lead this big health data. So we're quite a small group, but we work with big data. So we're not anywhere your size. And the timing is good for me to talk about this program because we just got an HRC program grant, our second consecutive grant to work on this data. So that's kind of good. So we're in business for another 5 years at least. So so it's quite good out of this last HRC round. And the program that I'm talking about, we call this one View 2020. So, and I'll show you there's View. It stands for Vascular Informatics using epidemiology and the web. And I know it's just a trite acronym, but actually it does describe what we do quite well. And so our focus in our research is vascular risk prediction. That's been our major focus, and risk management. And I'll tell you why you want to predict risk before you manage it. And the informatics part, it really comes from the fact that the data we use is big data. It's on a large scale. Our major science is epidemiology, and of course that's strongly linked to biostatistics. And we generate quite a lot of our own data. So we do use national data collections, but we also generate big data sets using web applications. So View is quite a nice name for what we do, and it's also, we're kind of taking a national view of vascular disease and vascular risk. So so that's the field. And 2020 is our current program. Our new program should end at the end of 2021. Actually, so it's not quite 2020, but I thought 2020 had a better ring to it. We're a relatively small team, but we cover quite a wide field. I'm an epidemiologist. Martedi is a Māori GP. Sue Wells is an academic, was a GP and has been an academic epidemiologist working with me for about 15 years. Andrew Kerr is a senior cardiologist, works as a clinician at Middlemore Hospital, but also leads View with Sue and I. Dan Ext is a geographer. Katrina and Roger and Patricia are all biostatisticians. Jim Warren is a computer scientist. Some of you might know Jim Warren. Jeff Harrison is a pharmacologist. He's just the new head of pharmacology. Rob Doughty is a senior cardiologist. He's actually also the National Heart Foundation chair in population health. And we have 4 PhD students, and we have a data manager. So it's kind of, and there's a number of other people who work with us, but that's pretty much our team. But we cover primary care, secondary care, but also because we're very strong on data analytics, we have a lot of people with biostatistical and epidemiological skills. And these are our goals. Our focus is that we want to develop accurate ways of predicting vascular risk. That's risk of heart attacks and strokes mainly. And the reason for having accurate prediction is we want to actually target our management to those who are truly at high risk. And with I guess a goal of a lot of what all of us do is to try to reduce inequities and inequalities in vascular disease burden. And there are major inequities in New Zealand. So I want to start, and please interrupt me at any stage if there's anything that you want to ask. Might be easier if I'm over here, mightn't it? So, I'm sorry, it's cut off on the side. Back in you've probably all heard of hypertension, which I should tell you is a meaningless construct, which is really interesting. But this is a typical old-fashioned bit of data on the importance of blood pressure. So this is increasing diastolic blood pressure, which you have two blood pressure, you have a systolic and a diastolic. We don't use diastolic anymore. This is so last century, which is interesting how rapidly things changed. But this is what the data that I was trained in is that increasing blood pressure, increasing risk of cardiovascular disease, increasing risk of heart attacks, increasing risk of stroke. Put them together, it's cardiovascular disease. And we used to focus mainly on what we call relative risk. This was the standard data that was used to define hypertension. Now, can anyone tell me where hypertension is? I mean, that was the data that was used to define hypertension. Of course you can't, because the risk is continuous from quite low levels. This is a nice blood pressure around 70, 75, but everyone, if you look at this data, pretty much everyone in this room has hypertension. And in fact, if you look at definitions, when I first started looking at how to define hypertension, it was in the late 80s. I'd done my PhD looking at risk factor profiles of New Zealanders, and I had all this data on blood pressure and on lipids and a whole lot of data, and I wanted to describe it. And one way to describe it was to use means and standard deviations, and the other way of describing it for clinicians was to use a clinically relevant definition like hypertension. So I went to the literature to find out what hypertension really was, and I came across multiple definitions. And interestingly, when I went to medical school, my clinical teachers used to define hypertension as a diastolic above 100. While I was at medical school, it was 95. By the time I left, it was 90. If you talk to medical students today, I hope none of them will say, when I ask them what's hypertension, they should say there's no such thing. But unfortunately, and possibly, I don't know whether people in this room, but people of your generation are still telling them that hypertension exists and it's 80. But you can have these multiple definitions, which are all meaningless. Yeah, Peter.
I have a question, Rod. If you showed the other side of that curve, presumably at some point there'd be not for stroke but for cardiovascular, some sort of risk, it would go up again. Is there a flat bit?
Yeah, no, and that bit that goes up is reverse causation. So the lower the best blood pressure is the lowest possible blood pressure below which you fall over when you try and stand up. So probably the ideal blood pressure is nearer 60 diastolic. But you're absolutely right, Peter, is that you will see curves that start going up, but it's pretty clear that those are people who started further up and because they're unwell have come down. And it's those, so there doesn't seem to be a lower level of blood pressure. If you can take out the sick people who have got a low blood pressure because they're sick, yeah, it seems to be, yeah, and of course you do get to a point where you do fall over when you stand up. But if you look at middle-aged Indian women, those really tiny women that you sometimes see around, really tiny, some of them have blood diastolics of 60. And they really have low blood pressures, yeah. Yeah, so it's pretty low, yeah. Okay, so, and the problem with a definition like this, the problem is that if you define blood pressure, hypertension up here, that's 5% of all 60-year-olds, and if you define it down here, it's 50%. So it has a profound influence on medical management, how you define hypertension. So this, I started reading about this in the late 80s, and I was quite shocked that that everything I'd been taught was wrong, and it was I certainly had problems with it. So I started reading everything I could about blood pressure to find out if there was something meaningful, and I came across the Framingham Heart Study, which I'd heard about and used before for a different reason. But what one of the things that Framingham did is that they said, let's look at cardiovascular risk not as a relative risk, but because in a relative risk, if I go back to this one, so these people here have half the risk of those people there. So we talk about a doubling or a halving of risk or something like that. That's a relative. So the risk in these people relative to those people, there's a twofold difference. What Framingham, what they really added to our knowledge is they said we should be looking at what we call absolute risk. So that is, what is an individual person's risk over, say, the next 5 or 10 years? And so what this figure does, and first I've moved to systolic blood pressure, which is what we now use in terms of when we're measuring blood pressure clinically. And this blue line, if it looks blue, that's the risk, the absolute risk of a cardiovascular event in a 50-year-old woman who has a blood pressure of systolic of 120, and if her blood pressure goes up, her risk goes up. But this 50-year-old woman has no other risk factors. So she's got an ideal, she's a non-smoker, she doesn't have diabetes, she's got the ideal lipid profile. But if that same woman also had a high total cholesterol, that's her risk. If she also was a smoker, that's her risk. And if she also had a low HDL cholesterol, that's her risk. So for the same woman, yes, as her blood pressure increases, her risk goes up. But all of these other factors are really important in determining her risk. So what it means is, and if you talk to people now about, if you ask a whole group of medics, what's hypertension, most of them will say a systolic of 140. But a systolic of 140 means a risk of 1% in 5 years for this woman, and 12% for that woman. So there's a 12-fold difference in risk, even among 50-year-old women with the same blood pressure. So the construct of hypertension is actually clinically meaningless. It's clinically meaningless unless you take into account all the other factors. And this is a kind of revelation that I had in the early 1990s, late 1980s, early 1990s, and I'd never been taught any of this. I'd never been taught, even though it's highly clinically relevant. It had been around, the Framingham study had been looking at this for some years, but it hadn't caught on. Somehow it hadn't caught on. So I decided that I would see if I could make it catch on in New Zealand. During the 1990s, I developed these charts, these risk charts, which basically take this data and put it on a simple chart. There's one for men, one for women, and there's a block. This is age. Each of those blocks represents a different age, and this is blood pressure up the vertical axis. This is lipids across the horizontal axis. And so, for example, you could take a 50-year-old male smoker who had a blood pressure of 160 on 95 and had a total cholesterol to HDL ratio of 6, and that yellow means that their 5-year risk of a cardiovascular event is about 10 to 15%, or something like that, 10 to 15. So this was a chart that we designed so a clinician in a busy clinical practice could predict their patient's risk. Okay, this was based on a risk prediction equation from the Framingham Heart Study, and I'll come back to the Framingham Heart Study in a second. So we developed these guidelines during the 1990s in New Zealand, and by 2003 we'd managed to get rid of all hypertension guidelines, all hypercholesterolemia guidelines, and we had one national unified cardiovascular risk management guideline in New Zealand. We led the world, New Zealand led the world in moving away from single risk factors to managing cardiovascular risk. But the issue was that our risk prediction equations were all based on a study called the Framingham Heart Study, and we were using data on 5,500 men and women from Framingham, Massachusetts, in the States, who had been followed between the late 60s and actually for 12 years, from the late 60s, early 70s. So 5,500 people followed for up to 12 years. And our question, even back then, was how relevant is a prediction equation from a 1970s US study to multi-ethnic New Zealand population in 2000, in this century. So we had this question back then, but we had no alternative. There was nothing, surprisingly, there was nothing else. And so, in fact, when we first started using this equation, it was in the first risk prediction equation or chart I developed was in 1993. So this was kind of more relevant then, but even by 2003 we didn't have an update. So so we decided we wanted to do something about this. So now, in terms of management, so why predict risk if you want to improve management? Well, what's interesting with cardiovascular disease, and it's probably common in a lot of conditions, is that it doesn't really matter how you got your risk. It doesn't matter how you got your risk. So your risk of a cardiovascular event could be 20%, 10%, 5%, whatever. But if you give people a series of pretty basic treatments, if you lower their blood pressure, if you lower their lipids, and if they're smoking, if you stop their smoking, you can halve their risk. You can halve their risk. And so if your risk is 20%, you can halve it to 10. If it's 10 to 5, 5 to 2, 2 to 1. So the benefits of treatment, so if you could give all of these people the same treatment, and they could all start with the same blood pressure. They could all start with the same blood pressure, but the same package of treatment will give you this much benefit for these people, and so on. So the benefits, and this is the key feature of cardiovascular disease, that the benefits of treatment are directly proportional to where you started in terms of risk. So it makes knowing your pre-treatment risk pretty important. And there's now good evidence from trials that that pre-treatment, so this is all based, the data I've shown you so far is all based on prospective epidemiological studies where you measure risk factors and you follow people forward. But there's now, this is a systematic review of data of blood pressure trials where they took about a dozen blood pressure lowering trials, these randomized controlled trials, blood pressure, drugs versus placebo, and they retrospectively worked out what their starting risk was, their baseline risk. And basically what this shows is the more you lower blood pressure, the better. And this is benefit. This is number of events avoided per 1,000 treated. So the more you lower blood pressure, the better. But your baseline risk is also a major determinant of your treatment benefit. So we now have both good cohort data that demonstrates how to predict risk, but we've got good trial data that shows that your predicted risk determines your benefit. And we've got the same for lipid lowering as well. So, so that's kind of the background. So what have we done in New Zealand? Well, we started pushing absolute risk, this risk-based approach in the early 1990s by developing risk prediction charts and by giving GPs, we gave GPs these charts, we developed guidelines, national guidelines, but was it having any effect? Well, in the early 2000s, we tried to find a data set in New Zealand to see whether GPs were treating patients according to their risk. And we managed to get some data from a Dunedin Royal New Zealand College of General Practitioners database. And we were able to get data from 25,000 individuals. These were men aged 45 and over and women aged 55 and over, who'd consulted a GP in 2000. And we wanted to find out how were they treating these patients. Okay, this was the only data we could find from general practice, and interesting. This data was really hard to get, and it wasn't in a form. It wasn't. They were happy to give it to us, but it was very difficult to extract. A lot of the data wasn't even electronic. It was they'd photocopied doctors' records, and this is back even in 2000. And the bottom line was that you could, of the data in these GP records, there was only sufficient data in the record to estimate someone's risk, to put them through that chart in a third of them. Only a third of them could you estimate risk. And among those who you could estimate risk, only about 28% of those who were known to be at very high risk were taking the drugs they should be taking. So we were very concerned. So this is about 2000. We subsequently, in our own research, and I'm jumping ahead slightly, but this was done on about 50 to 80,000 people. We subsequently showed that among people, and we've been predicting risk in large numbers of people since 2002, is that when we divided people into those who had had a previous heart attack or stroke, which is high risk, and different risk levels, we found about, this was done by 2006 to 2009, so this is not that long ago. We found that among people who were recommended for treatment by national guidelines, which was mainly these people in that sort of greeny line and over, those people were all meant to get treatment. And you'll see, and this, we felt that about 90% of these people should be on treatment. And you can see a big gap, that even those with previous heart attack, only about 60% of them were taking the treatments. Among those who were really high risk, but hadn't had previous heart attacks, it was nearer 50. And even this group down here, who were recommended for 3 drugs by guidelines, only about 40% were taking drugs. And yet down here, these are people who we believed they weren't recommended for drugs, and yet quite a few of them were being. So there was both under and over treatment. And as it happens, there's more people down here than there are up there. So the level of over treatment is probably greater than under treatment. So, and this was up until 2009. So it's a fairly big issue for New Zealand. So what are we going to do about it? And one of the reasons we feel, that's sufficient rationale for doing something about it. But just to add to this, this is looking at, this is the prevalence of cardiovascular disease in New Zealand by age and by a combination of ethnicity and deprivation. So let me just show you this. This top line, this blue line here, is the prevalence of vascular disease in Māori. I think this is Māori men, who are in the lowest deprivation. They're the most deprived. So the most deprived Māori men have the highest prevalence of cardiovascular disease. The purple is the least deprived European men. So they've got the lowest risk. And in the middle, the 2 lines that totally overlap are a combination of the most deprived Europeans and the least deprived Māori. So Māori have and the same with Pacific as well, they have a double whammy. There's an ethnicity-related issue and there's a deprivation-related issue. Now, they're very hard to separate those two, and our measures of deprivation are not that great. But, so not only do we have nationally, do we have this major differences in management and major, both under treatment and over treatment, whether you're Māori or not, but we also have some quite major disease burden issues. Okay, so that's kind of the background. So this is the cartoon that goes with our program, and our goal is that can we reduce inequity? So, if you look at this guy here is at the highest risk. Can't even see over the fence. This guy here is at the lowest risk. He's got a good view, and this guy's he's in the ideal situation in that that he can see everything he needs to see, and yet in the current sort of way we manage risk, if this represents treatment, we're giving them all about the same level of treatment. Some of them are over-treated, some of them are under-treatment. But basically, we haven't actually been treating according to risk. And what our goal is that if we can measure risk accurately, this guy who was over-treated there probably could do with a bit less. This guy is being treated appropriately, and this guy here needs more treatment. So that, conceptually, what we're trying to do is give some equity in the view of, it's actually a baseball game. We were thinking of putting a rugby game there, but we thought that was a bit too much work. But anyway, you get the picture. So, so our goal is to, if we can identify who truly is at risk, and we can take, these treatments work as well. The other thing is that the basic treatments for cardiovascular disease risk management are cheap. They're statins for lowering your lipids, they're blood pressure lowering drugs, lowering your blood pressure, and for some people a bit of aspirin. But also then there's the preventive things like eating less saturated fat. Despite what you read in the media, saturated fat is still bad for you. You'll have butter on your birthday, but no other time. Eat less salt. All those things that you've heard. Don't believe this wacky paleo stuff and that, yeah. Anyway, so and don't smoke. I mean, of course, that's a biggie. So anyway, but this is a very treatable disease. Does anyone know whether, do you think cardiovascular disease is increasing, decreasing, or about the same? Anyone have any idea? Increasing? Okay. Has cardiovascular disease death rates in New Zealand have declined by 90% since 1967. 90%. So I know people think it's increasing because we're getting fatter. But actually, life expectancies, we're gaining 5 hours per day in life expectancy. It's amazing. I mean, aside from getting fatter, everything seems to be going the right direction. Heart disease coming down, strokes coming down, cancer's coming down, everything's coming down.
You don't have exercise on your...
No, we don't have exercise. It's a fairly minor factor for cardiovascular disease. Yeah. It's important to do, yeah. It's important. Exercise is a good thing to do, but mainly what goes in your mouth for cardiovascular disease. A bit of exercise is good, won't do any harm.
Is that the same worldwide as well?
Across the Western world, yeah. That's amazing. It's just absolutely dramatic, and yet the majority of people think, we're going in the opposite direction. This is a very easy disease to modify. It really is. Yeah. Anyway, so what are we doing about it? So we're interested in using, I guess, big data to improve risk prediction and risk management. So the first thing that, having spent the 90s kind of getting clinicians using these cardiovascular risk prediction equations, which we did with only some success, is we decided we started thinking about this in around 2000. Why don't we give them this risk prediction, these equations, electronically? And there were two reasons we wanted to give it to them electronically. One is because when we asked them whether they used them in the late 90s, most of them said, yeah, we've used them. We use them occasionally, but we can never find them. And we said, put them on your wall. And they'd say, well, if we put everything on our wall that good people like you give us, we would need a room like this to put charts on. So we decided, and around about 2000, New Zealand general practitioners were computerising. So there was a revolution going on in primary care around computerisation. So initially we thought we would give them this chart just a PDF of this chart, and I just wonder if I've got it on there. I haven't actually got it on there. And then we gave them this chart on the computer, and then someone, and I still don't know who it was, sent me this very nice little Excel-based tool that you plugged in the risk factors and it spat out the risk. So it did this in a nice little tool. And it suddenly hit me, gosh, we want to validate this equation because this is based on American equation. Why don't we give GPs an electronic version of this tool and ask them if we can have their data? So I just sort of thought, ping, it just sort of hit me that, so we give them a tool that they can use clinically, but wouldn't it be great if they could give us their data back and we could use it to develop a new tool? And so the way that works is like that. So we developed this tool called Predict, and it's quite a sophisticated decision support system that I won't go into, but basically there's a series of templates which, when a GP presses a button, I want to risk assess, these templates come up, they try to pre-populate, they're linked to the electronic record. This is all the risk factors that they automatically populate from the GP's record. If the GP hasn't got it in their record, they can plug it in, the blood pressure, and it goes back into their record, and they press a button and it spits out what their risk is, and it even shows them on a chart. And then it can also give them some decision support, which I won't go into. There's a series of charts. They can even press a button, I think with this one, and it'll send some information to the patient about decision support. But this is a decision support system that was called Predict, and we've developed it in association with an Auckland software company called Enigma. So anyway, so what we basically did is that we designed Predict firstly to get evidence into practice, to give GPs the best evidence on how they should manage their patients. But what happens when the GP was actually predicting the patient's risk, we organised that the data that they collected got sent to a secure server. The data was there. Now, at the same time, because we're New Zealand, if the same people who are going through general practice, well, everybody, if they have a cardiovascular event, they get into a national data set. So if they are hospitalised or they die, they get into an... So this is happening in the background. This is our web, this is the W of view. This is our web-based system collecting the risk factors. And because we've got an NHI, you've all got a unique identifier, health identifier, we can join them together. So we can join these data sets together. We use an encrypted NHI, and we can make a new chart and get rid of the old one. So conceptually, that's what we designed. We designed a clinical system that makes it easier for GPs to practice good medicine, but every time they used it, we got their data and we linked it to outcomes, and that's what you need to predict risk. If you want to predict risk, you need a data set of risk factors, and you need a data set of outcomes, and you link them. There's standard risk prediction. You had a question?
No, is it real time like that?
Well, it's real time. The data is going real time. Yes, the data is going real time. We only link it once a year because it's a big deal. But in the future, you could do this in real time. But certainly, every time, I mean, once a GP has clicked the button and risk assessed, it's in our server. So the data is accessible in real time. Yeah.
So what number of patients would you have?
Okay. There you are.
Thanks.
We didn't get this. So we've got 500,000. We've got 500,000 patients. Framium was 5,000. And they've followed them for longer, but yeah. So we started in 2002, and we call this the Tony Ryle effect. Tony Ryle, we managed to get him to make cardiovascular risk assessment a national health priority, and because he was so anally focused on his targets, he used to ring individual PHOs up and tell, "You haven't met my bloody target." Apparently that's what he did. So we're indebted to Tony Ryle, and we now have, in the Auckland and Northland region, almost every general practice uses our software. There are some, maybe 10 or 15% use some other software, but of those that use our software, something like 85 to 90% of all eligible patients have been risk assessed. So this is a representative population. So it's large and representative.
What proportion of those would you have proper data for, and from like the demographics, the age and ethnicity?
Everyone. We've got no missing data on age, gender, well, occasionally, but age, gender, ethnicity, deprivation, smoking status, blood pressure, lipids, diabetes status, family history of CVD.
So Rod, how does that compare with other international? This must be the biggest.
It's the biggest prospective one. There's one out of the UK where they retrospectively scrape general practice systems and called Q-Risk, and that's really, really big, but they have a lot of missing data. But in terms of prospective cohorts in primary care, it would be the world's largest and most contemporary.
Is deprivation a one parameter?
At the moment, deprivation is a parameter. It's an area-based. People talk about postcode deprivation, where basically using census data, University of Otago group of researchers developed this thing called NZ-DEP, which takes together. They look at a small area and they look at house ownership, car ownership, people, employment, etc. And they've divided the country up into these deprivation scores. So it's not an individual score, unfortunately. It's a bit crude, yeah, but it is predictive, yeah. And we've now got 500,000. And what we do is, this is another version of that picture, one of those pictures I showed you. This is our increasing data set that we get from general practices. And I mentioned that we can link it to mortality and hospitalisations, but we can also, I don't know whether any of you heard of TestSafe. TestSafe is a regional laboratory database. We actually have every laboratory test done in the Auckland and Northern region. We have access to every laboratory test. So we know what happens to laboratory tests. We have an enrolment database of all the PHOs. We actually have all the drugs that people get prescribed if they're subsidised, which is most of them. We get all the drugs, actually on the whole country. And there's this thing called a National Virtual Diabetes Register, which is updated on a regular basis. So we have pretty amazing data. And probably this would be the world's cheapest, most efficient cohort generation, because the GPs generate it for clinical purposes, and the data falls out the back for us. And all these databases are available, and we have an ethics system which is mature in that they see that this is public good. So as long as we can prove to them that our encryption processes are really good, they're happy for us to link this data. We've got a Ministry of Health who have been really supportive. It's taken time. We took time to get this data, but they're now very supportive. And we have a Minister of Finance, Bill English, who has told all his departments, share your data with academics. He's made this, he's told all of his, he said, look, there's so much data out there that we're never going to use within our ministries. Share it with academics. We're all on the same side. We're all trying to and make use of academics. So that's been great. So we had great access anyway, but our access has got even better in the last couple of years since Bill English has kind of told everyone to do that. So it's great. So this is our growing cohort. This is hospitalisations and deaths that we can link, and that's all the dispensed drugs in labs. So we sort of just put them all together. This is just a little bit of data that I wanted to show you, is that, so this is based on, I can't remember, 2012. This is based on about 270,000 people, this data set. And interestingly, if you look at risk, out of our 270,000, the first 270,000 people, 13% had prior heart disease or stroke. They're already known to have heart disease. And that 13% actually accounted for 46% of all the events that have occurred during the follow-up. So this relatively small group account for almost half of all the events. These are people with diabetes. 14% of our whole population have got diabetes, and they accounted for another 17%. And then the almost 3/4 of the population who either don't have prior CVD and don't have diabetes now only account, for a bit more than a third of all the events. So this is before we've developed our risk prediction equation. So it is interesting is that cardiovascular disease is not uniformly spread through the population, and so we're designing. In fact, interestingly, our diabetics in New Zealand are not at very high risk anymore. It's interesting of cardiovascular disease. So we're developing an equation that puts these people together, and so here are these. So we've now actually developed one equation, but we're about to update it. Our data is coming through so quickly. We developed an equation in 2013 based on, in fact, there's 200,000 people in there because there are about 70,000 who we had to exclude. But 200,000 people in there we had in 2013. We've now got almost 400,000. So we almost doubled our numbers in a couple of years, and so we're updating this equation based on 400.
So with prior CVD, that's not an indication of hypertension, I take it, that's something...
Well, it could be. It could be because, but basically the best predictor of a future event is a past event.
So there's been some hospitalisation.
There's been hospitalisation. And see, that's a nifty thing that we can do because we've got, this is our predict population, but we know if they've been hospitalised before because we've got data in New Zealand actually that goes back to 1993. So we know whether they've been hospitalised at any time in the past. So we've got pretty good data.
It doesn't fit with your comment though, or maybe it does, but this idea that it's such a treatable disease. So people don't take the pills, people modify their diet.
Because what? Because...
Well, yeah, sorry.
Are you looking at this group?
Yeah, that's the largest group of...
Yes, but but interestingly, if they didn't take their tablets, they'd be a lot more than 46%. Yeah. So, but it's a good point. About half of these are adequately treated now. About half, or maybe even a bit more. If in 2016 it might be near 60%, but we could do a lot better. No, you're absolutely right. If they took their pills, that would be even less. It'd be even less. They're just very high risk. Yeah.
So it's interesting that you say you're going to group the people with diabetes and no cardiovascular disease history and all diabetes together.
Well, together in the one risk prediction equation, but they get separated because in fact, the equation we're developing allows you to predict risk for every single individual. So all I meant is that we're putting them together in one data set. And so our risk prediction equation, we're not actually at the moment developing a separate risk prediction equation for them and for them. We have Well, we are going to, but we're not sure we need to because we can by putting a variable into the model, do you have diabetes? Yes, no. That's probably adequate. But we're not sure. When we get enough data, which we actually probably have already, we'll probably develop a separate one as well. But when I say we're putting them together to analyse. We're not putting them to. They don't. If you're diabetic, you will have a different variable in the model than if you're not.
That's why I was asking. But I mean, in terms, it might simplify the equation for prediction, but that's not really an issue. That's done, And you're absolutely right. And I
I'm telling you, the only reason I'm telling you putting it together is because I wanted to show you how many people we've got in that. But we're actually going to see, we have so much data now that we're ultimately going to develop separate equations in Māori and Pacific and South Asians, in young and old, in diabetics and non-diabetics. And of course, you're absolutely right, it all goes under the bonnet. It's just for the clinician, they don't need to know how many equations there are. There can be multiple equations. No, I mean, you're absolutely right. But this was the data set that we were working on. I said 200,000. So we were working on 205,000 people, 114,000 men, 90,000 women. There's more men because men have higher risk, so we risk predict them earlier. But look, I mean, the numbers, we've now doubled, as I said, we've doubled this number. We had, back at this stage, we had 74,000 European men and 57,000 women. Those are now double. We've now got actually close to 50, about 25,000 Māori men, 25,000 Māori women. I mean, we've got big numbers. We've got large numbers. Even, I mean, this used to be 10,000 people was a big study, and we now think that that's a tiny study. I mean, that's the big data era. It's the numbers are huge. The first study I did, which I thought was a huge deal, was 1,474 people. It was a random sample of the Auckland population back in 1982, and I thought, wow, that was a big deal, 1,400 people. We throw those out before breakfast now, if they've got missing some data. Events, we had 4,500 events. So we almost had more events than Framingham had participants. In fact, now we've got far more events than Framingham had participants. Interestingly, very few fatal events now. For every, so you see there, it's only about 10% are fatal of the events. And what was the major finding? Well, and this was kind of, for us, quite surprising initially, although in retrospect, it's not. This is predicted risk using an equation. This is observed risk. And so when we predicted risk using Framingham, so this here, 5, if Framingham predicted the risk was 5%, we then observed it looking in our population. And if these predicted risks are right on that line, then predicted risk equals observed risk. Anything below means over-prediction. That seems counterintuitive below, but that's over-prediction. So what this says is that if you're predicted to be at about 12% risk, your risk is about 6 or 7%. So what we've pretty much found is that Framingham over-predicts risk by up to 2-fold, between 1.5 and 2-fold. Whereas our own equation, almost by definition, is right on the money, because we're using the same data, the same data, but even if we divide, there are ways of dividing your data set into derivation cohorts and validation cohorts. But pretty much when you've got a big data set like ours, you can get it right. So we've been over-predicting risk in New Zealand, at least recently. And I don't know whether any of you know much about risk prediction equations, but we had assumed that because of risk prediction equation, it has a baseline function, which is kind of the average risk in the population, and then it has a variable for each of the risk factors. So we had kind of naively assumed that we know disease is declining in New Zealand a lot, but we know the risk factors are declining. So we'd assumed that the change in risk factors are accounted for in the equation. But it seems that that's not true. Is that the most important component of a risk prediction equation is this baseline sort of function, this hazard. And you're nodding, you can see, is that, so what happens is the most important variable by far in a risk prediction is the average risk in your population. And then if you're a smoker, that takes you up over the average risk. And if you've got the ideal lipids, that takes you below the average risk. But the function that's most important is this baseline hazard or survival. There's a hazard, or the opposite is the one minus the survival function. And so what we've realised, and this hasn't really been discussed in the literature, that the most important, if you're developing a risk prediction equation, you need a contemporary cohort. You need a cohort the baseline, the average risk of the people you want to apply it to. Yeah, Peter.
So is that saying, if you go back to your Framingham study,
Yeah.
is that saying that the Framingham study, which was, 20 years ago?
30 years ago, yeah,
30
yeah.
years ago, so the actual risk will have come down massively.
Yeah, so that was right back then.
So that's not the main conclusion.
Yeah, but now it's over-predicting risk, yeah.
All these big numbers,
Yeah.
what do you gain out of having very large numbers?
What we gain out of very large numbers is in particular that we can start looking at the smaller high-risk populations like Māori, like Pacific, like the elderly, because one of the things, I haven't got time to show it, but if you're Māori or Pacific or South Asian, you have an additional risk over and above this. People who are over 75 seem to be in a different category again. People who are under 50 seem to be in a different category again. So the benefit of having large numbers is that you can look at some of the high-risk subgroups. So that's one of the benefits. The other benefit in effect, the large numbers, we could have done with fewer numbers, but pretty much in Auckland and Northern, we've got everybody. We've got everybody because we generated this data set by giving GPs a clinical tool. And it was a clinical tool that was meant to be used in everybody. So as a result of using it in everybody, we got data on everybody. Yeah. So it does, and it also allows us to develop risk prediction equations quite rapidly. So Framingham had to wait 10 to 20 years to get sufficient person time. We can actually generate equations rapidly. So it's a good question. Yeah, we could do with less data.
Is the important thing not the total number of people, but the total number of events?
Yes, absolutely. It is and we often talk about numbers of people as a proxy for the event, but you're absolutely right. And it does also mean that down here, these people are the bottom deciles of risk, they're very low risk. So if you want to estimate their risk with any sort of precision, you do need big numbers because they're very low risk. Yeah. So I just wanted to say, interestingly, Framingham, I'm going to run out of time, but one good thing about Framingham is they get them in the right order. They just get the risk number wrong. So what this is here, this is deciles of risk. It's actually the same data on the previous slide, but put a different way. These are deciles of risk, which those are also deciles of risk. But rather than have them, the units here are predicted risk, whereas these units are just 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Put them in order. And on this axis now, this is the proportion of all of the events that occurred in follow-up. So what you want is, if you're in the lowest decile of risk, you want that to be quite a small proportion of all the events that occur. Okay? And for the people in the highest decile of risk, you want them to account for most people. If your equation didn't work at all, every decile would have 10% of the events, so it'd be like that. So anything sort of steep is good. Blue is Framingham and red is predict. And what is fascinating, even though Framingham overpredicts risk by up to twofold, they pretty much get them in the same order that predict does. So they're quite good at ranking people, they're just not very good at getting the risk right.
So it's stating below risk too,
yeah, it is, but it is. So predict is slightly better at the bottom and slightly better at the top, but not a hell of a lot better at ranking them. So Framingham, they had all the right risk factors, they just are not contemporary. Yeah. And look, just to cut through, I just want to say that we're doing something similar in secondary care. We've got a new cohort called ANZACS, the All New Zealand Acute Coronary Syndrome program. It's also, we call this a quad improvement program because in secondary care, the clinicians didn't actually want a guideline. What they wanted is their data, which is really interesting, because clinicians, if you work in secondary care, someone comes in, you treat them, and they go, and you never see them again. What they want is data on, they want to know how they treated their patients, and we've been feeding them back data on how they treat them. But we do the same thing. We've given them software, we can link it to everything, just like with the primary care. So increasing cohort, We can add mortality and drugs. We have quite a lot of data on what happens to them, and these are our numbers. We've only been going, we started in 2008, but we only went national in about 2013. But we're now collecting data on almost everyone who comes into hospital with an acute coronary syndrome, and we collect data on everyone who goes to a cath lab in New Zealand. Every cath lab, public or private, all their data is now in our system. So that's a secondary care cohort. And finally, we have a third cohort. And what we realised is that we've got all of these national and regional databases. If you link them together, you've pretty much got the whole country. Because pretty much every New Zealander has some interaction with the health sector. At least every 3 years when you have to re-enrol with a PHO. You have to re-enrol don't know? Every 3 years you're meant to get a letter, if you've been in, and you have to re-enrol. Yeah. Anyway, if you put all these data together, you get pretty much the total New Zealand population. So we've created this population, this cohort called varians, which we call vascular risk in adult New Zealanders. And when we put, we can put everyone together in a cohort. We can then link to hospitalisations, and we can link to drugs. So we can kind of create this national cohort for, say, 1 year. Like in this one, this is pretty much everyone who had an interaction with the New Zealand health sector in 2006. So we've got a 2006 cohort, and we can follow them up over time because we've got follow-up data on hospitalisations and deaths. And you might not see the numbers, 2.5 million people in our cohort. The census for the same population said there were 298. So we were missing, this was just a 1 year cohort, we were missing 15% of the New Zealand population. But there's not many studies that get an 85% response rate. So even with what we did, we had 85% of the population. And we're developing a risk prediction equation in 1.7 million. and so one of our plans is, Predict is developing a clinical risk prediction tool so that clinicians can use it, because it's got blood pressure and lipids and all that, so it'll be used clinically. And we're developing what we call a low information risk prediction equation that we can apply to the whole country automatically, because we're only going to use routinely collected data. So with this equation, we can just press a button and everybody in New Zealand gets risk assessed. And so if we know what your risk is, and we also know what drugs you take, and we know about your hospitalisation rates, we're in a position to be able to feed back to the sector how people are managing risk across the whole sector. So we've kind of got something for everybody, something for GPs, something for hospital docs, and something for policymakers in terms of risk prediction linked to risk management. And it's kind of 5 o'clock, so I mean that's kind of what we do. So you can, and also the other thing is we can put them all together. So that's so we can put ANZACs, we can put Predict, and we can put our other, because we've got an NHI, we can link all of our data sets together. And our kind of goal, and Corey will be pleased about this because this is one of his visions from the beginning, is that our goal is to have a large-scale sort of representative and sort of sustainable national data set which covers everything in in sort of vascular disease. Now, that's vascular disease because that's our area of expertise. There's no reason why it couldn't be done in other areas. And if you're focused on cancer or respiratory disease, yeah.
Are you considering following the change in the guidelines? For instance, it's a guideline change, the medication change.
Yeah, the guidelines are about to change. Yes, I mean, well, we can follow how management. We can follow what happens to management as a result of guidelines. Yeah, yeah.
What about genetics?
Good timing for that question, because what we decided early on was that let's get the infrastructure in place. Let's demonstrate that we can do this without any threats to privacy, and so let's get it set up, and then let's start talking genetics. So the timing is right. It's how you get that data. I mean, I had this idea, and I don't know how possible it is, but given that we have labs on everybody, I mean, everyone's getting, most people get a lab test every other year or so. Would it be possible sometime to save a little bit of something from every lab test specimen and done in a you could actually encrypt it on the spot. I think there would be ways of collecting genetic material on almost every New Zealander in a really low cost way that could be done. I think could be done anonymously.
But you also want to do it early enough that it's a useful predictor early on.
Yes, but because we have access to every lab test ever done, you potentially could. I mean, we're looking at adults, but we get them on everybody.
There's no retrospective. I mean, I'm just wondering, if someone says, look, I do not want this being done to my... Is there given blood there?
Yeah, I don't know. I mean, I don't know what blood's being saved at the moment. We decided not to go there early on because we wanted to get... I mean, there are some people who, this kind of data linkage scares, and we thought they'd be more scared if we started in with genetics initially, but I think it's the obvious question to come up, yeah. So we have a data infrastructure. We can do some important work without genetics, both in terms of developing new prediction equations, plus looking at risk management and linking them. So it's got both a fundamental research component, but it's also got a quality improvement, a major quality improvement component. But yeah, there are many options now.
You've got no list of...
Well, actually, sorry, that just reminded me. There's one other new initiative. Sorry, I don't know why I forgot. I was looking at. There's this new thing called the Integrated Data Infrastructure, which comes from Stats New Zealand. And Stats New Zealand are creating a super database that not only includes all the data I've shown you, but also includes the stuff. And if you work within they've got a very secure environment. If you work within that environment, you can actually link individual data on all these people.
Somebody through the NIH?
It's true. Well, the NIH is the NHI is specifically for health data, but they've got a way of linking it. They've got a way of doing it. Yeah.
So I'm really surprised there is no concern about assurance.
About what?
The assurance. Europe, it might be impossible currently, because if you have a high risk, you cannot have it's difficult to have money from the bank. So this kind of...
Oh, but no one knows, I mean, no one knows who, we don't know the name of the person. Okay. This is all anonymous. It's all done with encrypted NHIs. So we never have any information on an individual, as a named individual. We have data on every individual, but we don't know who they are. We don't know who they are.
But surely if you have inputs from many different data sources, there reaches a point where you can uniquely identify an individual.
Well, you potentially could, but the reason they give us this data is that we wouldn't do that. And we keep them all separated. We keep them in a form that it would be very difficult for someone to do that.
Suppose you were in the States and your name was Donald Trump.
Yeah.
Would you have the same wish not to identify?
I don't know. But, I mean, the other thing, because, again, and one of the reasons why we've kept our focus on vascular disease is knowing someone's blood cholesterol is perhaps not such a big deal. I mean, we've tried to keep away from, we don't do anything with, venereal disease, HIV, or anything like that. So we kept it fairly...
If you're coupling into these...
Well, we haven't got there yet, but if that happens...
I mean, given that they're not using NHI numbers, are they?
No, but there's... the Stats New Zealand have a way of doing the linkage. They now have...
There's your danger point.
That's your danger point. No, I think you're right. And this is part of the future. So at the moment, we're not linking any of our clinical data into this, but there could be a danger. I think you're right. But that's, at the moment, the only way to get that stuff, to work on that stuff, is within a Stats New Zealand kind of, it's almost like a sealed chamber, you have to go, and anything that comes out of it, they do a privacy check on it. So they won't let you get out individual people. Yeah.
So I guess the current mode of operation in terms of how this is useful is that it's a sort of an event-driven thing. You know, you have a symptom, you go to the doctor, they look at your risk and say, actually, you should be looking at modifying something.
Well, no, the event, in fact, because almost everyone sees the doctor for something, we've had over 90% of the eligible population have had a risk assessment.
But is it, I mean, my question was going to be, given the fact that there's all these data being collected for other purposes, is it getting to the stage where, you know, the letter actually automatically comes through the post to the individual to say, actually, we've collected all this data for you from all these sources, you really should get your...
Well, that's a possibility. That is a possibility, yeah.
Heading in that direction?
So everything that we're doing anonymously could be done using a named... Yeah, and I guess what we want to do is we want to do as much as we can. I mean, we've been given such great access because everything we do is anonymised, although linkable. But I'm sure we'll get to a point where that question is going to come up. Given how much you know, should we be breaking this code for individuals? But except if it's done by your GP, because so the GP. So what we'll do is we'll do everything anonymously, and we'll say, actually, if you want to identify the patients in your practice who you'd like to bring in for an early consultation, you can do this with identifiers. Yeah. So I think that's part of the future. There's no doubt that.
It's a genuine predictor.
Yeah, and most patients would expect that. Yeah. So, I have to take. I left my car on the road because I couldn't. It's too big to go under here, and it's 5:10. Do they tow you away? So I'm gonna.
Roger's already gone.
I'm gonna have to, guys. I'm gonna. So I answer a question as I'm finishing this, but Sorry.
So how do you know you've got enough variables? And corollary to that is, when do you decide to add?
Right. Yeah. I mean, we could really benefit from more variables. But the sort of variables we really want are highly predictive. Sorry.
Give me your key and I'll go and shift it and see that.
Oh, it's a van. It's a VW van. Just down. It's parked just down past your building.
Okay.
So it's the only VW sort of van.
On the side, right?
Yeah, on this side, silver.
You're going to add that to your collection.
Yeah. So it won't go underneath. So if you, I'll come out. Yeah. So they say prediction is difficult, particularly about the future, and we could definitely benefit with some really strong new predictors if we could, things like, coronary calcium is something that people are looking at. It would be great to get some other markers. We're on the lookout for new markers. We're definitely on the lookout.
Let's thank God and thank you for coming over.
Well, thank you.